Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go get your top 200 study guide, great little PDF, 31 pages, absolutely free. Simply an email will get you access to that. We also get you updates when we've got new podcasts available and other content. So again, go check that out at reallifepharmacology.com. All right, on today's episode, I'm talking test prep and practice pearls on the PPIs. So this is a gastrointestinal medication, proton pump inhibitors. They are commonly prescribed in practice. They are considered or broadly classified as an antacid type medication, and they suppress gastric acid secretion by irreversibly inhibiting the hydrogen-potassium ATPase pump on gastric parietal cells. So essentially they shut down the acid pump in the stomach. Common medications here within this class, omeprazole, Prilosec, brand name, esomeprazole is Nexium, pantoprazole is Protonix. Those three are the three that I probably see most commonly used, with omeprazole being the top dog there. Others, lansoprazole, Prevacid, dexlansoprazole, Dexilant, and ribeprazole, that is Acefex. What are we going to use these medications for? GERD, erosive esophagitis, healing and prevention of stomach ulcers, peptic ulcers, gastrointestinal ulcers, NSAIDs-induced ulcer prevention or GI prophylaxis. Also see this used when patients are on anticoagulants, antiplatelets. They need them for cardiac purposes, for example, and patients are at risk for GI bleed. You also see that prophylaxis or prevention for the use of PPIs. H. pylori treatment management, obviously with antibiotics, we're treating an infection there. Zollinger-Ellison syndrome, Barrett's esophagus, stress ulcer prophylaxis, tons of different uses for PPIs. All right, so medication administration, I'm not going to go through each individual dose. I have covered the majority of these PPIs individually, so if you go to reallifepharmacology.com, you can search and you can find the PPI you want specifically, or if you want to delve into more specific details on each one, go to reallifepharmacology.com, hit the podcast tab, and you should be able to search on the right-hand side for the one that you want. So in general, administration, most PPIs ideally should be taken 30 to 60 minutes before breakfast. This is a patient education point that I come across occasionally, where they're saying, it's not working that well for me, just taking it a couple days or whatever. So making sure that they're taking it, again, ideally 30 to 60 minutes before breakfast. That'll help kind of shut off those proton pumps. If it's dosed twice daily, usually we take that second dose before the evening meal, not like right at bedtime. Now, have I seen it at bedtime? I have. Is that the ideal way to do it? Probably not, but that might be effective enough for some patients. From a pharmacokinetic standpoint, I'll talk CYP2C19 a little bit. Some of the PPIs are more prevalent with affecting CYP2C19 than others. Generalized adverse effects of PPIs. In the short term, PPIs usually are very well tolerated. Maybe you can have a little headache or diarrhea or constipation or a little change in the GI function. But it's, again, these are really pretty well tolerated, particularly in the short term. Now, the longer term adverse effects I'm going to take a little bit more time on. One thing I've seen in practice for sure is specific deficiencies. Vitamin B12 Okay. And this is, again, chronic long-term use, 3 months, 6 months, years of PPI use. B12 deficiency is possible and is associated with PPI use. So pay attention to that, monitor that over time. If you get somebody with, anemia, neuropathy, those type of symptoms, good idea to check a B12 level and make sure the PPIs aren't dropping that. Metformin is also commonly used in diabetes. So that combination of a PPI and metformin, definitely a combo I've seen a ton in our geriatric polypharmacy patients. And those two can both cause or contribute to B12 deficiency, and it's definitely something that I have recommended looking at in practice for those taking that combination. It can exacerbate that even further. The other big deficiency that I pay attention to with PPIs is magnesium levels. It can cause low magnesium. So again, paying attention to that is certainly important. It can also possibly impact calcium absorption, also may affect iron deficiency or iron absorption as well. Remember, iron is typically best absorbed in an acidic environment. Well, with the use of PPIs, we're essentially taking away that acid environment, or at least reducing that acid environment, which could, impair the absorption of iron. So pay attention to that if you note that patients have iron deficiency or symptoms of iron deficiency, such as, anemia or restless legs, for example. Bone health. This is something I pay attention to. If you see a patient with a osteoporotic fracture, if you see them taking a medication like alendronate for bone health, I take a good double look and see if they're taking a chronic PPI. If they are, I really make sure that reason for the long-term use is justified. Okay, so in the world of deprescribing, trying to reduce medications, this kind of gives me another bullet to say, hey, obviously their bone health isn't great. They're taking alendronate for osteoporosis. Can we get rid of that PPI? Can we taper them off? Can we taper them down, reduce the dose? Whatever we can do, to try to reduce that risk. Another thing to pay attention to is a couple of infections. C. diff risk may go up with the use of PPIs, as well as potential increased risk for community-acquired pneumonia. Not super strong correlations with this, but again, if I see a patient that's having, recurrent C. diff, for example, which I have seen, maybe they're on chronic medications, maybe you see antibiotics used for C. diff frequently. This is another good patient, good example where it's like, hey, we got to look at this PPI. Is there something else that can be done here? Can we get them off it altogether? Can we reduce the dose? So again, paying attention to that when you see new diagnoses come into play, and give us a good example of reassessing the use of that PPI. Other things that come into play potentially, there have been kind of reports of associations with kidney effects. Again, potentially another negative downside where it's like if you're seeing a patient with significant renal problems, okay, can we take a look at that PPI? Is there anything we can do with this? Can we switch them? Can we reduce the dose? Is there anything we can do there? So another one there. And then it can be a challenge to get patients off of these medications. Rebound, acid secretion or acid hypersecretion is possible when patients stop taking this medication. And so in general, let's say you've got somebody on omeprazole 40 milligrams, I'm going to likely do or recommend a long taper off of that medication. So, maybe we go down to 20 milligrams once a day, see how that works, see how the patient's doing. Then from there, maybe we go to 20 milligrams every other day for a month, 2 months, that type of thing. I've seen even cases of, every third or fourth day, just in that slow taper process. And so that rebound hypersecretion definitely is a real thing, and it's particularly problematic when patients have been on the medication for a super long time. All right, let's take a quick break from our sponsor, and then we'll work on drug interactions and other high-yield educational points. If you're in the market for any pharmacist board certification study material, like BCPS, ambulatory care, geriatrics, BCMTMS, NAPLEX, go check out meded101.com/store. Got a growing list of resources there that can help prepare you and pass your exam. We've had thousands of customers and helped thousands of pharmacists prepare for and pass their exam. We can absolutely help you too. So again, meded101.com/store. In addition, if you're a pharmacy technician, nurse, med student, we've got tons of other links to resources, review courses, books on Amazon, crossword puzzle books, making things interesting and helping educate and learn pharmacology a little bit better. Again, all those links, meded101.com/store. All right, moving on to drug interactions. Always a good idea to look these up individually, so I'm just going to throw out kind of a couple of high-yield things. With PPIs, you got to think about absorption. So PPIs can reduce the absorption of certain medications. A couple of the azole antifungals, this is oral absorption, ketoconazole, itraconazole. That's kind of a classic example. So these are generally medications that require a more acidic environment for absorption. And with PPIs, you potentially reduce or take away that acidic environment. So those azole antifungals, oral administration, of course, those are good to remember there. Iron I alluded to before. So if you've got a patient with iron deficiency, they're taking iron tablets. By reducing that acidic environment with PPIs, we may potentially reduce or impair that iron absorption. The other one I did want to mention, definitely one that I've seen come up on board exams and pharmacology exams, is omeprazole and esomeprazole pretty strongly inhibit CYP2C19, and this may actually decrease the activation of clopidogrel and reduce the effectiveness of the medication. So in that situation, I'm looking to utilize potential alternatives to these. If the patient absolutely needs a PPI, we're probably going to use pantoprazole. But again, many of these situations, we've been able to just, taper off the PPI, potentially go to an H2 blocker like famotidine, for example. So there are some potential options to kind of get around that theoretical interaction with clopidogrel. So again, something to pay attention to there. From a monitoring standpoint, certainly we're going to be monitoring, GERD symptoms, ulcer symptoms, whatever we're treating. You want to pay attention to the need for continued therapy, okay? So, reassessing these medications at 4 weeks, 6 weeks, 8 weeks. Do they still need it? Was this an acute issue? In practice, I've seen many cases where somebody started an NSAID, for example. Let's say ibuprofen, 400 milligrams 3 times a day. They're taking it for some acute pain, and now they're having some heartburn and some GI upset from that NSAID. And so, that's a situation I've commonly seen where a week or two later, now they start a PPI because they're having GI upset, and that relieves the GI upset. Now, let's say that back pain's resolved. They're no longer taking ibuprofen. Now the patient just continues on, with their PPI. So really pay attention to how those PPIs are added and taken away. Magnesium, B12, paying attention to those levels if long-term therapy is needed with a PPI. The bone health, I alluded to that as well there. Again, deprescribing, so important with these medications. It's one of the kind of high-yield deprescribing medication classes that I've seen. Many patients will continue PPIs years after the original indication has gone away, whether that be GERD, whether that be GI prophylaxis, stress ulcer prophylaxis in the hospital. That's a common one. Whether that be prophylaxis because they're on an anticoagulant or on an antiplatelet medication and now they're not, or an NSAID like the example I used before. Okay, so really important to pay attention to that. Utilize lowest effective dose. That's obviously common therapy, and then consider stepping down. Look at that every 6 months, year if they're on chronic. Is this a medication we still need? Can we step them down to maybe a lower potency agent like famotidine and step down further from there? And so again, those, and if you're discontinuing, this is another issue I've seen. Somebody on, let's say, pantoprazole 40 milligrams. Well, the provider's trial dose reduction was basically stop it and see how they do. And it's like, well, if they've been on it for, months to years, like you're going to likely run into that rebound acid hypersecretion, and that patient's not going to feel very good. And they're likely going to have a return of their GERD type symptoms. And so really important to recognize that tapering is the best way to get them off a PPI medication. In that situation where you go cold turkey from 40 milligrams to nothing, now the provider thinks in their head, like, well, there's no way they can get off their PPI. They had symptoms when we tried stopping it in the past. Well, maybe it wasn't stopped very appropriately in the past either. So again, pay attention to that. Really important thing to recognize. A couple other things. PPIs do take a little while to work. Typically, you're not going to see maybe the full effects for 3 to 5 days. So that's a good patient education point. They don't work as quickly as a Tums antacid. Okay, so that's an important thing to note. It's also an important thing to note if patients just have sporadic symptoms of heartburn based upon something they eat. Let's say they have heartburn every 2 weeks, every 4 weeks, just kind of a nuisance symptom. That's a good example for an antacid. Calcium carbonate, Tums type of product, where we don't need to use a chronic PPI if it's just kind of a sporadic acute relief need. That's definitely more appropriate to use kind of an as-needed PRN medication there. All right, well, I think that's going to wrap up the podcast for today. Hopefully you picked up a few practice pearls and test prep nuggets. With that said, if you enjoyed this episode, do me a huge favor. Leave a rating, review on iTunes or wherever you're listening. Feel free to reach out to me as well. Questions, comments, suggestions, mededucation101@gmail.com. And of course, support the sponsor, meded101.com/store. Your purchases there go directly to help support this podcast. With that, I'm going to sign off. Appreciate you listening. Take care, and I hope you have a great rest of your day.